Hey Justin, I got your email and I got all the PowerPoints. We're gonna get started in a couple minutes. I'm just gonna give a couple people more time to come in if they decide to.
Yeah, okay, sounds good.
Okay.
No news.
I sure hope Fushun didn't destroy your wallets like she did for me, cause we're getting Jinglu and Topaz for the Star Rail 1.4 update. How's it going, everyone? This is Kay, and let's talk about the strengths and weaknesses of the 3 featured characters and who you should pull for on the upcoming banners. Starting with Jinglu, she's a Destruction Ice character whose primary kit revolves entering an enhanced state called Spectral Transmigration. Her basic is a normal single target attack, which you won't really use. Her skill and ultimate will be her primary way to attack, more so because of the stats it provides. This skill is a single target attack that provides 1 Syzygy stat. Her ult is a single target that deals adjacent damage, and it'll also provide 1 stat. So the stats are important because of her talent. When Jinglu possesses 2 stacks, she'll automatically go into the enhanced state, which gives a huge crit rate buff depending on the talent skill level, around 40% at level 1, so it's a major boost that offers stat flexibility for relics. On top of that, she gets a 100% action advance when entering the enhanced state. Now, when she's in this state, you can't use her basic attack, only her ult and her new skill. Whenever Jinglu attacks, she drains all other party members' health at 4% of their max HP. You won't have to worry about them dying though, as the drain cannot kill them. Now, on the plus side to having your allies' HP drained is that Jinglu's attack stats gets a huge buff whenever she attacks at 540% of the total HP that was drained, capped between 90% to 225% of her base attack, depending on the talent's level from 1 to 15. Keep in mind, numbers can change post-release. The drained isn't bad, but having an ally like Wolcha can help gain back the loss of health. She can possess up to 3 stacks, and if she has 0 stacks remaining, Jinglu will lose her enhanced state. So while she's enhanced, her skill changes and will deal stronger single target damage, provide a bit more energy regeneration, and will also deal adjacent damage. Using this skill does not consume SP, but will remove 1 stack, and as I said before, 0 stacks means goodbye Spectral State. This is where you want to use her ult after entering the Spectral State in order to extend her enhancement, because it'll provide 1 stack upon use, which means you'll max out the stacks limits, giving you 3 enhanced skill attacks, and the ult will be stronger because of the talent's buff. Additionally, her A6 trace increases her ult's damage while in the Spectral State. Other abilities she has is that her A6 increases effective resistance while in that Spectral State, and A4 gives a small advance forward when using her regular skill. This can help slightly with turns because you want to use her skill twice to enter enhancement, not skill and ult. Bronya can help tremendously with this. Jinglu's technique creates a dimension around her that will freeze enemies. When going into battle, she gains 1 stack and regenerates some energy with a chance of freezing enemies. So let's be honest, most of us can't afford higher indolence, but her E1 buffs her crit damage for 1 turn when using her ult or enhanced skill. Also, if there's only 1 enemy on the field, it will add damage that was meant for adjacent increases the cap percentage, so even more damage. Lastly, E6 gives 1 stack upon entering the spectral state, maxing the limit and will increase the crit damage by 8 points. So an obvious issue with Jinglu is that she drains everyone else's health. I can't really call this an issue though, because their drain is so little, but typically with 3 enhanced skills, and it also means everyone will lose 60% of their health, aside from Jinglu, of course. Again, it's not bad, but if you have weak sustain characters, consistently losing your health no matter how small certainly isn't a good thing. Another issue is that her energy requirement for her ult is quite high, being at 240. Yes, her enhanced state increases energy regeneration for her skill, but at 140, it's still above the norm, which makes sense because you spamming her ult is a bit too powerful. Her speed at 96 is also on the lower side compared to others. On the good side of things, she's a very solid DPS character, especially thanks to that crit rate buff when she's enhanced, which makes her so much easier to know compared to other DPSs. You can concentrate on attack percentage and crit damage stats, or speed if you want to. Another plus is that she doesn't consume a lot of SP, aside from the -2 in order to gain the required stats. In terms of character synergy, Baranya for obvious reasons, but Pella being as positive and a fellow ice user means she's amazing with Jinglu. Topaz is a Fire Hunt character who revolves around follow-up attacks, mainly from her adorable pet Numby. If you're familiar with Jingyu Wen's Lightning Lord, Numby is similar and acts as an auto-attacking fifth party member with its own speed stat. But first, Topaz's basic will be considered a follow attack after unlocking her A2, and that plays into her skill. The skill will mark one enemy with a perfect dead state, which increases the damage they receive from follow-up attacks. It's very helpful for herself, obviously, but can benefit other allies who also has follow-up attacks. Only one target can have the mark, and the amazing thing about this skill is that it can auto-assign the proof of death to a random target if no enemies have the mark. Because of this feature, it means you can conserve a lot of SPs, but as mentioned before, it's random, so if you don't like you got it, you can manually select a new target by using her skill, which will...
Okay.
Okay, so we'll just go ahead and get started. I just wanted to give people time to come if they, so I don't miss anything. But, okay, so for Musculoskeletal, I'm going to be switching between the PowerPoint that you gave me and then my own PowerPoint.
Okay.
Just because I have, like, notes that are incorporated in my PowerPoint as well, that I just want to make sure you have all the information.
Sounds good.
But they pretty much mirror each other because I had a chance to look through it. So, okay. So, and you guys have
an exam on that one
on musculoskeletal. Okay, and then I also pulled. So this is going to be. We'll do some NGN questions and just questions about musculoskeletal in general. Okay. If we have some time. And this will give us feedback, so when you make your selections or whatever, it'll tell us the rationale right away as, like, what's right, what's wrong, and why. Okay? Okay. So, our musculoskeletal system. Okay. Let me go to... my PowerPoint for this one. Okay. So, our musculoskeletal system, okay? So, it does more than just support, our making us stand upright, things like that, okay? It also not just provides support, but protection, movement, mineral storage, hematopoiesis. Support, obviously, our skeleton, right, is our body's framework, and it supports our organs, right? And that goes along with protection, right? So like our skull houses and protects our brain, our ribs protect our vital organs, right? Our breastbone protects our heart and our lungs. Our pelvis helps protect our digestive organs and reproductive organs, right? Movement. So we have skeletal muscles, okay, that are attached to our bone, right? We have muscles that do different things. But our skeletal muscles enables us for our bones to move. Okay. Mineral storage. So in our long bones, okay, we store red and yellow bone marrow. And for our red and yellow bone marrow, so our red bone marrow produces red blood cells, right, through the process of hematopoiesis. And then our yellow bone marrow is more fatty tissue. But in times of life-threatening, okay, only in life-threatening situations where we have massive amounts of blood loss, our yellow bone marrow can actually begin to form red blood cells. But that process only happens when the body thinks, okay, we're about to die. Okay. Along with mineral storage, we store things like calcium and phosphorus, and we'll get into that a little bit more when we start talking about osteoporosis. But both are very important for bone formation, okay? And we'll talk about osteocytes and things like that and how that plays. But we store these minerals in our bones, okay? And then we release these minerals when we need them. We have our skeleton is divided up into two skeletons. Okay, so we have something called an appendicular skeleton and an axial skeleton. So here, if you look, the pink or purple, depending on what you see, this is going to be our appendicular skeleton. So our appendicular skeleton is our clavicle, humerus, right? Our extremities, our pelvis, okay? And then our axial skeleton is our entire skull. So zygomatic bones, ear bones, all that, everything that's inside the skull, along with our spine and our rib cage. So if it's easier to remember just that, you know, your skull, your rib cage, and your spine is your axial skeleton, then we know our appendicular is everything else.
Makes sense.
And then again, appendicular, just our upper extremities, our lower extremities, right, along with our hips and our shoulders. Skeletal muscle structure, okay? So 85% of our body heat is generated by our skeletal muscles, right? So by our movement, okay? That's why when you start moving around, right, you start getting hot pretty quickly, right? Versus when you guys are sitting in the classroom, right, and you're not moving, you guys get cold, right? Because we're not generating enough heat, because that body heat comes from moving around, okay? And our skeletal muscles are composed of hundreds and hundreds of muscle fibers, okay? So that's what our muscles are actually composed of, okay? They're just a bunch of muscle fibers, and there's different layers to our muscles, okay? And when we get into compartment syndrome, I'm actually going to show you a very quick video on the muscle layers so that you can see how we relieve compartment syndrome. Tendons are a form of connective tissue as well. And we have tendons and ligaments, and they do different things. So our tendons anchor bone to muscles, and our ligaments anchor bone to bone. So the way I remember that is tendons, you know, like when you tenderize meat, right? Muscle. So tendons anchor muscle to bone. So just tendons tenderize meat, right? AKA our muscles. And then ligaments, we know if our tendons are muscle to bone, then we know our ligaments are bone to bone. I don't think I have any. Yeah, I don't have any notes for that one. Functions of a muscle contracting. So when neurotransmitters send signals to our brain saying, hey, we need to move or, you know, contract our muscle, it's literally all or none. Either we're going to have a full contraction or we're not contracting at all. There's no such thing in muscle stimulation where only a part of the muscle is contracted. It's the entire muscle because it works as a whole unit, okay?
Yeah.
when we're talking about muscle tone, okay, people get confused with muscle tone, and they think sometimes it has to do with movement, and it has nothing to do with movement because, for instance, I could be like a bodybuilder. Let's say Arnold Schwarzenegger, okay, when he was bodybuilding. Even though he had, his muscle size, right, was relatively bigger, it didn't make him be able to move any differently than, say, you or me, right? The movement was the same. It didn't change depending on the muscle size. And that's also true when, say, somebody gets into, let's just say, a car accident or something happens where they have like a CVA and they are paralyzed on one side, right? That can happen to anybody. The muscle tone has nothing to do with the size of the muscle. So, a person can become paralyzed, right, on, say, their right arm, right, and they could have a ginormous, bicep. But again, muscle tone has nothing to do with movement, right? The muscle itself, right? That's more of nerve endings, right, and things like that. So if somebody becomes paralyzed, right, or atrophy, right, where the muscle starts to shrink, okay, that's what we mean by atrophy. And some people have atrophy on one side of the body versus the other. So if you are right-handed and you only start using the right side of your body, but you neglect your left, you're going to start having muscle atrophy on your left, okay? We have different types of movement, right? I'm sure you remember that from term 1, right? When we talk about range of motion and things like that. Remember, we have active and we have passive. So when we do active range of motion, right, we are generating active range of motion. We're generating that ATP, right? We're breaking down that energy because we are the one doing the movement. We're passive, right? We're doing it for the patient, so they're not really using so much energy. And then we have just different, this is just a quick little slide on the types of body movement. And like I said, I'm sure you remember this from term 1, flexion, extension, abduction, adduction, rotation, supination, pronation, dorsiflexion, and plantar flexion. These are just different types of movements that our skeletal muscles can make, okay? I'm going to switch over to the other PowerPoint just to make sure. Okay, so we have our joints, right? Now our joints connect bone and bone, okay? And that's what helps us, right, move our arms, move our legs, right, bend, okay? Now, in between our joints, we have two things going on. We have cartilage, okay? We have cartilage within the joint that basically acts like a cushion, okay? And so, and we'll talk about when we talk about osteoarthritis, where over time, that cartilage starts to degenerate or decompose a little bit, right? Because of age, right? So over time, right, that cartilage gets thinner and thinner and thinner, and then we end up with osteoporosis because we have just bone rubbing on bone, right? We no longer have that cushion. And then we also have something within the joint. So we have our cartilage, right, in between our joints. And we also have something called synovial fluid, okay? And the synovial fluid kind of acts like, just like most fluid in our body, right? Think of like with pericarditis, right, we have fluid around our heart, right? The pericardial sac, right, holds fluid. And just like amniotic fluid, right, this the pericardial fluid and the synovial joint fluid, right, acts like a cushion, okay, as well, and offers protection, right? So just like amniotic fluid protects, say, a baby, right? So that's why when we, like, if a pregnant woman starts jumping up and down, right, it doesn't harm the baby.
Yeah.
And with our joints, it works the same way. That's why we can run, jump, right, sprint, and do different things without having pain in our joints, okay? Now, when we talk about rheumatoid arthritis, which we'll get to in a little bit, that has to do directly with the synovial fluid being attacked by the body. Whereas with osteoarthritis, it's degenerative, okay? There's nothing being attacked, it's just age-related,
Yeah.
okay?
Sure.
Right. Let me see. Okay, so we have 600 plus muscles, okay? Big, small, of all sorts of sizes, okay? Makes about 40 to 50% of our total body weight, okay? That's why we tell people if they want to pack on weight, right, we want to build that muscle. We don't want to add fat, right, because adding fat can put us in, cardiovascular distress, can cause diabetes, right, different things. So when we tell people to gain weight and we want them to gain muscle, right, we'll tell them to, like, work out, right, eat properly.
Yes.
And then this is just a quick view of the internal structures of our muscle, right? So remember tendon, so it's connecting to the bone, right? Muscle to bone. And we have different, there's, different forms of connective tissue and layers, right? We have our blood vessels, muscle fibers, the fascia, okay? And like I said, we'll get into that when we do compartment syndrome. But in our wrists and our ankles, right, we have something called tendon sheaths, which are literally just basically a lot of strands, right, of tendons, right, that basically help us, move our wrist and move our ankle in the way that we can, right? Because there's not real muscle down there, it's more of tendons, okay? And they also contain synovial fluid as well because, as you know, right, we have joints in our ankles and in our wrists, and that's why we're able to rotate our wrist, rotate our ankle, right, go back and forth. Our fascia, okay? This is, I don't know why he has such a tiny little head.
That's Attack on Titan. It's a.
Oh, really?
Yeah.
I was like, what?
Yeah.
I was like, that's a little. I've been watching Castlevania on Netflix.
Oh yeah.
I've been rewatching it. There's a new
Doctor, right?
Yeah, there's like a new spin-off, and I haven't like seen it. So I was like, and it's been forever since I watched the season. So that I was like, this looks like one of the monsters. Like,
yeah, that's a different one. That's AOT.
Oh. So, okay, so we already kind of talked about tendons, ligaments, things like that. But our fascia is deeper in it. It's part of our muscle, right? And so when we have things like compartment syndrome, it's our fascia that gets tight and gets constricted, right? And when we don't release that, we can actually cause permanent damage to the body, okay? Let's see, nerve and blood supply. Okay, so obviously, right, we need, in order for us to move, right, any muscles, right, remember that all or nothing contraction, okay, we need our neurotransmitter, and our neurotransmitter here that sends impulses to the muscle is acetylcholine, okay? And so this is a chemical, okay, signal. So not only is it electrical impulse, but it's also a chemical signal as well, okay? And so both need to happen in order for us to contract our muscles, okay? In our neuromuscular junction, we have one artery, two veins, and one nerve, okay? And then, and for whatever reason, right, we either voluntarily we want to move our muscle or involuntarily, okay? This is the reason that this happens, okay? Because sometimes you, like, say if you put your hand over a hot stove, right?
Yes.
You just move your hand automatically, right? You don't even think about it. It's just something that, it's a reaction, right? Or if somebody throws something at you, you catch it. Sometimes it's just a reflex, right? And that's where our neurotransmitter acetylcholine plays a part in. Let me go back to my other slide. Okay. Okay. So diagnostic examinations. There's a couple of different diagnostic testing we can do to look at our muscles and our skeletal system. Okay, obviously you know what an X-ray is, right? That's when we're looking at what, like breaks, fractures, right, broken bones, things like that.
Yeah, correct.
If a patient has like screws or pins in, right? Did something get dislodged, right? Then we have a myelogram, okay? And a myelogram, so like with our nerves, we have something called a myelin sheath that covers our nerve. It's like a sleeve, right? Kind of like your sweater is protects your arm, right? When you put on a sweater, it protects you from the cold. Where our myelin sheath acts just like that sweater, right? It's just a protective covering of the nerve, okay? And so in order to look at, say, the spinal cord, okay, and our vertebral column, right, we can inject dye, right, directly into the spine to get an X-ray of what's going on in the spinal cord and our vertebral column, okay, and that's why it's called a myelogram, because it's the dye is directed into that myelin sheath.
Oh, okay, that's what that means.
Mm-hmm.
Okay.
So then we have something called nuclear scanning, okay, and this is just basically where it's like a camera, okay, and just like on your phone how you can record images, right? That's basically what this is, right? So we can see and record how the muscles contract or what's going on, right, when we're dealing with, if there's something going on with movement, okay? So this gives us more of a recorded image of what's going on in the body. You know what aspiration is, right? And we're not talking about, aspirating as far as choking, right? This is a needle aspiration, okay? And we can do this when we're trying to remove fluid, like if we're trying to, do, say like a spinal tap, right? Remove cerebral spinal fluid, or if we're sticking a needle into the joint to remove some, that synovial joint fluid that I was talking to you about, because we need to see what's going on under a microscope, right? Is the body really being attacked? Because that's one way we can diagnose rheumatoid arthritis, okay? If we needed to. Now that's a little bit more invasive than we would like to, because we don't like to aspirate or do anything like needle biopsy wise unless we absolutely have to, because it's invasive and it's always painful, right? We always have to inject a local anesthetic, and it's never fun, okay? I've had needle biopsies before on my thyroid, and even though they inject a local anesthetic into my neck, I can still feel the pressure, and it still stings and it hurts afterwards. So it's just not fun all the way around. An MRI, okay? So our MRI is, we can look at any abnormalities, deformities, right, going on with the bones, the joints, and the soft tissues. And a lot of people get MRIs and CTs confused, right? MRI is a quick look, where a CT is a more in-depth look, okay? This is why when somebody has a traumatic brain injury, we're like, do a stat head CT, right? Because we want a more in-depth look into the tissues, because not only can we look at, bones, joints, soft tissues, but we can look into ligaments, tendons, right? We can look deep into tumors, right? Fractures that are so tiny that they won't pick up on an X-ray, okay? So our CT is more in depth than our MRI, okay? We also do something called a bone scan, okay? And this is normally when we're checking for bone cancer, okay? Or, an inflammatory bone disease, okay? And this gives us a pretty good view on what's going on. It'll help us determine, look at benign and malignant tumors as well, okay?
With the bone scan or the CT?
What was that?
The bone scan or the CT?
The bone scan.
Oh.
So the bone scan is used to detect metastatic bone cancer.
Okay.
Because bone cancer is, okay, so I'm sure you guys have heard that, like, pancreatic cancer is extremely painful. And it is. Okay, pancreatic cancer, like, we give them all the drugs, like, because it's just very, very hard. Same thing with bone cancer. Bone cancer is very, very painful.
Yeah.
Okay, so that's why we use a bone scan, because we want to know more in depth, because just like with any cancer, right, you can have cancer in a certain part of the body, and it can always metastasize to another part. So even though I say, if a patient has bone cancer, right, those cells can metastasize to, say, the liver or the lungs or somewhere else in the body, not related to the bone, right? It's still bone cancer, but those cells have now migrated to other locations. And arthroscopy, okay, so this is just arthro, right, joint. So this is just an endoscopic examination, right, to visualize that joint, okay? This is something we use especially for arthritis.
Okay.
Then we have an endoscopic spinal microsurgery, okay? And it's basically, any type of surgery, right, we want to be cautious, but especially when we're messing with the spine, right? And we're very cautious when we do spinal surgery, right, because we don't want to compromise the spine, right? It's very high risk for infection, high risk for damaging surrounding tissues. So an endoscopic spinal microsurgery, right, prevents a lot of that, okay? Because we're just going in into a very small, minute incision, right, with our equipment, and it'll help reduce the risk of infection, and it helps reduce damage to surrounding tissues. We also have something called an electromyogram, okay? And just, again, if you just break down the word electromyo, muscle, right? We're just basically insert little electrodes with the needle, okay, onto the skeletal muscle to see, to record our electrical activity, right? So if somebody is having paralysis, right, or they're paralyzed, right, and we can't really understand, okay, well, what's going on? Like, there should be no reason for, if there's no real explanation, right, for the paralysis, then we're going to go ahead and do an electromyogram and see, is it something going on with the nerve? Is it the muscle itself? Where is it? Maybe the muscle's not getting adequate blood supply, right? And that is stuff that once we do an electromyogram, we can kind of start brainstorming why that is. Let me see. I'm trying to do, okay. And I'm pretty sure, yeah. Exomyogram, MRI. Okay, so again, with our MRI, no metal, no jury, titanium's okay, right? Because it's literally magnetic.
Of course.
CT, same thing. Yeah. We talked about aspiration, okay. Okay, inflammatory disorders. Okay, cool. Yeah, ours pretty much mirrors each other, so that helps. Okay. So rheumatoid arthritis, okay? So we talked about it a little bit, right, where it is the synovial fluid that's being attacked by the body. So this is an autoimmune disease, right, because the body's attacking itself. And in this case, it's attacking that fluid we talked about, right? And for this for this older woman, okay, look at her, I'm going to zoom in a little bit here. Look at her hands. Look at the joints. Look at her, on her fingers, her knuckles. They're really enlarged, really inflamed, right? So her right hand here, it's probably her dominant hand. But her left hand here, it's very contractured. It's deformed, okay? She has no function, okay? So because this is an autoimmune disease, okay, we worry about all the same stuff just like we do with all other autoimmune diseases, okay? Because we're going to give, corticosteroids. We're going to give pain relief medication, right, NSAIDs, right, to reduce inflammation. Because the big thing, we cannot reverse the damage. We cannot stop this from progressing, but we can control it, right? We can try to control the progression as a whole. So when we do our assessment, okay, our patient's obvious joint pain, right? That's usually the first sign and symptom, okay, and along with tenderness, okay. This can also cause an inflamed heart and lungs. Obviously, they're going to have limited range of motion as time progresses, right? Some edema, right, and they may even have a fever, okay, because their body is stressed. So, like with any autoimmune disease, right, stress management is key, okay? So, we want to, because the body's attacking its own proteins, right, we want to make sure that we reduce any stress in the body, and not just, emotional stress, but physical stress, right? Surgery, if maybe a patient, maybe even if they catch the flu, right, that puts stress on the body, okay? Physical exertion, so them overworking themselves, okay? Childbirth, right? That's a stressor on the body. So if I have a patient who has rheumatoid arthritis, and I know that they have to have surgery done for whatever reason, what do you think, what meds am I going to give them before surgery?
Corticosteroids, maybe?
Corticosteroids, good, and what else?
To help reduce stress. I don't think we went over too many of those. I mean, is it like some sort of pain reliever? Or?
Mm-hmm. A pain reliever, yeah. So, what kind of meds? Or you just give me a category of medication that will help with that inflammation.
Okay. Is it an NSAID?
Mm-hmm.
Okay.
Hit it right on the money. NSAID, right?
Yeah.
And so because they're in the hospital, we're going to give it via IV.
Yeah.
Because it's chronic, right? What kind of pain do you think we're worried about?
Chronic. I don't know, really.
A breakthrough pain.
Oh, okay, yeah.
We're worried about breakthrough pain. So that's why people with autoimmune diseases, it's very important that whatever their medication regimen is, right, that we're very vigorous with it, right, and that they take their doses appropriately, and just arthritis in general, right, because we don't, the main thing is that pain, right, pain, discomfort, tenderness, and we don't want them to lose any more loss of function. We want them to still maintain a normal life as much as possible. And unfortunately with RA, right, it's progressive, right?
Yes.
So we're gonna make sure that we give their their pain medication as prescribed, right? So that way we don't have any of that, breakthrough pain. Let's see. So medical management, controlling inflammation by giving anti-inflammatory drugs, provide pain relief, reduce clinical symptoms, prolong joint function, and slow progression of joint damage. Teaching, right, balance of rest, okay, because we don't want them overexerting themselves, okay. Make sure they take their meds, they need to exercise, and they're going to get with physical therapy for that, okay. Modify their diet, so anti-inflammatory foods, right. There's a bunch of foods that are great to help with inflammation management, okay. So we're going to teach them about that. And everybody responds a little different. Some prefer heat, some prefer cold, right? So we're going to give them hot or cold packs depending on what their preference is, right? And then maintaining safety, right? Because depending on where the rheumatoid arthritis is affecting joint-wise, right? If it's really bad in their legs, right, then they become a fall risk, right? Losing balance, things like that. So that's why safety is always, put in there. Osteoarthritis, okay? So remember, RA is the body attacking itself, okay? But osteoarthritis is a little different because we expect our older people to eventually develop osteoarthritis
Yes.
because it's degeneration of that cartilage. So remember I talked about the cartilage being that cushion, right? So much like if you had to say sleep outside and
Yes.
you bring your pillow with you and you lay your head on a rock, right? And you're laying on your pillow, right? That's your cartilage, right?
Yeah.
You don't really feel that rock too much. But if I was to give you, say, an airplane pillow, right? Okay, you're gonna feel a little more, right? You're gonna be a little bit uncomfortable. But then as time progresses, right, that pillow starts to deteriorate, or we take the pillow away. Now your head's just laying on the rock. You're not gonna be able to sleep, right? It's gonna be uncomfortable. So that's kind of what osteoarthritis is. Just over time, that cartilage starts breaking down, okay, and it's just bone on bone. And when bone on bone rubs together, you can hear it. It's called crepitus, okay. When bones literally just rub on top of each other, it kind of sounds like grinding, like a grinding sound. And so because of that, it causes damage to the bones, right? Because we don't have that cartilage cushion. So one of the main deformities that this can cause is these nodes, right? So we have Heberden's nodes, and then we have Bouchard's, okay? So it's just the location, right? Is the only difference. So our Heberden's is in the very top of our finger joint, where our Bouchard's is in the middle joint here. And how I remember that is because Bouchard's is so like brachial. It's closer to, say, my, I just B and B, right? So it's closer to my brachial artery. So that's how I know that Bouchard's is more proximal to me, where my other one is more distal to me. Kind of same with our rheumatoid arthritis, right? The pain, the stiffness, joint edema, okay, deformities. But this affects mainly our hands, hips, knees, and our cervical and our lumbar spine. So our neck and our lumbar spine. Okay. And that's where mainly people complain of the pain. Okay. So balance rest periods, right? Same thing with RA, right? Because we're not trying to put added stress on the body, and still encourage their ADLs. And if they are overweight, right, this can make arthritis worse, right? So because we're putting extra pressure on the joints, so we might need to modify like a diet plan, right? Give them some weight loss techniques, right? Talk to them about their exercise regimen. With arthritis, what exercises do you think somebody could do that would minimize pain?
Arthritis, I would say probably just walking, something low impact, maybe swimming.
Good. Swimming.
Yeah.
Swimming is a very big one for arthritis in general, okay? And we want to encourage that because with arthritis, okay, this is with rheumatoid and osteo. The worst part of the day for them is in the morning. Okay. And it's because, remember we talked about our skeletal muscles, the movement is 85% of our heat generation, like how we generate our heat. So remember, when you're cold, everything constricts, right? As we warm up, things start to dilate.
Yes.
So because of that constriction, right? Because in your sleep, you're not moving around, right? Like you do when you're awake. So everything is constricted in the vessel, and that's why it's so painful.
Yeah.
But as they start moving around, right, they start to feel a little bit better because now our blood vessels have dilated, right? There's now warmth in their extremities and things like that.
Yeah.
So what we tell our patients with arthritis is to take an anti-inflammatory before they go to bed, okay? And take one as soon as they get up in the morning, okay? To help with the pain and the inflammation that they're feeling, right in the morning. Winter months are the worst for arthritis patients. They are the worst, okay? Because cold sets in, right? And the cold can get they can feel it right into their bones, okay? And then again, because cold constricts, right? It's going to make everything more tighter and worse. So remember, winter time, right? We really want to push, take an NSAID before you go to bed, an NSAID when you wake up, right, to help, and then just as needed throughout the day. Let's see, For intervention and teaching, right, encourage those ADLs, that weight reduction we talked about, staying on top of their meds, physical therapy, and then, again, safety is a concern. So if they're having trouble, because osteoarthritis affects hips, if it's affecting their gait, right, make sure that they have a walker available, or a cane, okay? Gouty arthritis. Okay, so this is a little different type of arthritis, okay? It's still joint pain, okay? But the cause is different. So RA is autoimmune, right? That synovial fluid being attacked. And osteo is just degeneration of that cartilage. But gouty arthritis, think of it almost kind of like kidney stones, okay? A lot of it is going to be our diet. So with kidney stones, it's high amounts of calcium, right, in our urine that causes those stony deposits. Where this one is our uric acid levels are very high, okay? And so there are tophi, okay? Those are those crystals, okay? They're just crystals of that uric acid buildup. So the main symptom that you see is an inflamed big toe. Right, so anytime you see pain in the big toe, that should be your cue. Oh, I've got gout. Right, it says this question has something to do with gout. Okay, and like I said, the big thing with this is medication, but also their diet. Their diet is going to play a big thing into this. So no organ meats, no alcohol. Okay. Because no smoking, okay, because that all makes it worse, okay, that all contributes to that uric acid buildup, okay. Usually at night they complain of excruciating pain, okay, edema and inflammation, and this can last anywhere from 5 to 10 days. So we're going to tell them to modify their diet, right? We're going to give them medication. And there's different types of gout medication. Some gout medication prevents uric acid from building up, and some medication breaks up uric acid buildup. Okay? So they can be on one or the other or both, okay? But again, the main thing here is that patient teaching, because if our patient is taking those medications, but then they're still not modifying their diet, right?
Low purine.
It's not, it's not going to help anything, right?
Exactly.
They're just kind of going to be spinning their wheels. And so when we test for uric acid levels, we can test it with a urine test and a blood test as well. Okay, and we're going to do a CBC to kind of look at our white blood cell count and just look at everything as a whole. Okay, osteoporosis. Okay, so we have something called osteocytes. Okay, osteocytes are mature bone cells. Okay, mature bone cells. So we have two types of bone, or our bone is composed of two types of bone. We have compact bone and we have spongy bone. Compact bone is that hard substance that's if you ever look at a bone, right, it's hard, right?
Yeah.
That's that compact bone, that toughness.
Shaft, yeah.
But inside the bone, it's spongy, okay, or porous, okay? And so this picture here, this shows you, this is what our bones actually look like on the inside, okay? So this is normal. But with osteoporosis, what happens is our bones get more and more porous, right? So we get bigger and bigger and bigger holes, right? And so within our bones, we have, we do have blood vessels and things like that, right?
Mm-hmm.
But as you can see, right, the bigger the holes get, right, the weaker the bone gets,
Yes.
right? So how we get how we go from, say, this first image to this last image is by calcium and phosphorus. Okay? And our calcium helps, that's, as your mom always tells you, oh, drink milk, right, you build strong, healthy bones. And yes, that is important. But our phosphorus is also important for that, too. Because phosphorus helps break down old bone cells. So the problem with osteoporosis is we have not enough calcium and we have too much phosphorus. Okay? So, we want to decrease phosphorus, right? We want to increase our calcium. So we'll tell them to, say, take a calcium supplement, things like that, right? Along with some vitamin D. Because vitamin D helps with calcium absorption in the blood. And remember, we get our vitamin D from the sun, and we absorb it through our skin. But when you say buy milk, right, if you look on the milk carton, it says fortified with vitamin D, right? Because we know it has calcium, but they add that vitamin D in there to help with the calcium absorption in our body. So caffeine contains high amounts of phosphorus, okay, and that contributes to bone loss as well. So unfortunately, if our patient's a big coffee drinker, you're gonna have to do some decaffeinated coffee, right? Because you're just adding more to the problem. Alcohol as well. Alcohol can interfere with calcium and vitamin D absorption, okay? We want to decrease sodium and animal protein because that all can contain phosphorus in it as well. And then we can tell them to increase their calcium in the foods that they eat, but most likely we're going to tell them to take a supplement, okay? Because they're probably going to need more than what they're going to receive from food. Milk, yogurt, turnip greens, cottage cheese, ice cream, sardines with the bones inside of them, and spinach are all really good forms of calcium. For our exercises, right? So kind of what we talked about with osteo, or just arthritis in general, right? Moderate walking, biking, swimming, right? Because it's going to take that pressure off the bones and the joints, okay? But weight-bearing exercises can help with improved muscle tone. And as we improve the muscle tone, that'll prevent further bone loss, okay? But we want them to start out very light when they're first starting out, okay? And so what's going on? How do we get osteoporosis? How does that even happen, right? So remember I talked to you about we have those mature osteocytes, okay? That's this. Okay, these are our mature osteocytes. We have osteoblasts and we have osteoclasts. Okay, so think of it like a construction company. Okay, we have some people in the construction company that are demolition, right? That's our osteoclasts. And then our osteoblasts are the people who come in, right? They put in their cabinets, the hardwood floors, right? They start building it. Okay. So that's what's happening, right? We have a normal, healthy relationship between, right, we have demolition going on and we have rebuilding going on at the same time. But with osteoporosis, what's happening because of that increased phosphorus and not enough calcium, right? Our osteoclasts say, like in this picture, here they're using a pickaxe. For osteoporosis, they're using dynamite. right? So they're demolishing that house, right, or that bone faster than we can start repairing it, right? Or doing the repairs, okay? So our osteoclasts are breaking down bone faster than our osteoblasts can repair the bone, okay? So that's how we end up with osteoporosis, okay? We have too much of something and not enough of something else, okay? So hip and knee replacements, okay? Interventions are kind of moderatively the same with a couple of exceptions, okay? So with knee and hip, we both, for both, we monitor pain, right? We treat the pain. We're going to have them turn, cough, and deep breathe and use an incentive spirometer and monitor I&Os. And then we're going to encourage early ambulation, okay? But why would I want, if they had surgery on their knee and their hip, why am I giving them an incentive spirometer? Why am I having them cough and deep breathe?
I'm guessing they were under a lot of opioids when they have these surgeries. So maybe they're just...
No, not necessarily.
Then I don't really know what the...
We're trying to prevent something. What do you think we were trying to prevent?
Pneumonia, maybe? Or...
What was it?
Pneumonia?
Pneumonia, exactly.
Okay.
Exactly. We're trying to prevent pneumonia.
All right.
Because, we just put a large amount of stress on the body.
Mm-hmm.
They're put under.
Yeah.
And so, we're trying to prevent that pneumonia.
Okay.
We're trying to prevent, right, that, that bacteria just from sitting in there, right? So this is what we're trying to prevent, okay?
Yeah.
Why do we want to encourage ambulation? What are we wanting to prevent there?
DVT.
DVT, exactly. So, with our knee replacement, it's a little bit easier to encourage that ambulation, right? Obviously, we have to watch how the patient is walking, right? And,
Yes.
we're not going to have them walk long distances, right? But with our hip, it's a little different because our hip is connected to what? Our femur, right?
Yes.
So we're not only worried about a DVT, but now this is, the hip has to bear the weight of the upper body, right? Everything's sitting on top of the hip.
Correct.
So sometimes, right, we may need to take a little bit of time before we can ambulate that patient, right? So we're going to turn them, but we're going to give them anti-embolism, like stockings and things like that, okay?
Yeah.
And because of where, the hip, and we have all that, here, actually, I'm going to show you. Let me pull up an image. And I should actually incorporate it in here. I might as well. Blood. Let's see. Fine. I used this one earlier.
Okay.
Let me copy it and I'll see if I can. Okay. Okay, so this is why we have to be careful with hip replacements, okay, and why we have to do our neuro checks, okay? Because, so this vein here, okay, that connects to it'll connect to our femoral. This is called our iliac artery, okay? And it's broken up into three pieces, right? Common iliac, external, and internal.
Mm-hmm.
But just know that this is our iliac artery, right? Because our hips are here.
Yes.
So what happens is sometimes, right, there can be compression on this artery, and that's why we do our neuro checks, okay? because we want to make sure, because this can eventually go into our femoral, right? If there's compression here, right, we won't have blood supply to our lower extremities, okay? And obviously we don't want that, right? We don't want that compression. So that's why we do those neurovascular checks for a hip replacement, right? Because we want to make sure there's no compromise to either the nerve or the vein, okay, of the iliac vein. For a hip replacement, we're going to make sure that they have a raised toilet seat, right? Because we don't want them, bending down really low, right? Again, they just had hip surgery, and they're probably not going to be able to do it anyway. It's going to be really painful, okay? And then for both, provide education, right? Do's and don'ts, right? And a lot of that's going to, PT and OT are going to, or fit PT mainly, right? They're going to be the ones to set those parameters for what they can and can't do, right? Because they're going to have follow-ups with them. We have this is interventions for a fractured hip after open reduction and a bipolar hip prosthesis. Okay, so an open reduction or an internal fixation. Okay, so like here. I'll zoom in so you can see, okay? So there was a fracture on the collarbone, okay? And we have to put in a fixation device, right? To basically hold the collarbone in place, okay? Because we can't cast a collarbone, right?
Yeah.
So we're going to put this metal strip over it, and with screws, we're going to lock it in, and it's going to cover the bone like this, right, until the fracture heals.
Okay.
Here's an x-ray of that. This is kind of what that looks like, okay, in x-ray view. So with an open reduction, okay, or an internal fixation device, okay, we need to let them know, hey, there's a lot of things you can and cannot do, okay? For instance, you cannot put direct or put bare weight, okay, on that area. So say right now we're talking about the clavicle, right? That's our example. So we're going to tell them, don't put your backpack strap on that side. Don't put your purse on that side. Don't carry your toddler on your neck. Parents like to do that at Disneyland and things like that, right? And their legs are going to dangle over that clavicle, right? So we don't want any kind of weight. No kind of weight on that clavicle or any kind of fixation device, right, for at least 6 weeks to 3 months, okay, depending on how the fracture is healing, okay? Minimum 6 weeks, okay, max to 3 months, okay, because we're trying to protect that fractured site, okay? Depending on where it is, right, we can prop a pillow between their legs under their back to maintain a good position. We're going to turn them every 2 hours, right? Again, depending on where that fixation device is placed, right? And we're going to help them with their range of motion because they're going to be very stiff. They're going to be in a lot of pain, so they are probably not going to want to do it themselves, okay? That's where we have to provide that passive range of motion, and then eventually they can assist with that active, okay? And we don't want them overextending, right, hyperextending themselves either. So that's why we're going to help do it for them until they get the hang of it. With our hip fractures, okay, we're going to put an abduction pillow, so just like here in this image, because what we don't want is we don't want the legs to come together. And the reason we don't want them to come together is because it will cause misalignment, okay, and can mess up or reduction or a prosthesis, okay? So they're only going to do that for about 2 to 3 months, though, okay? So we don't want them fully closing their legs, right, thighs together kind of thing, for 2 to 3 months, okay? So we're going to avoid hip flexion for the first 10 days at 60 degrees, and then they can go to 90 degrees for 2 to 3 months, okay? Where if we had a hip replacement on say the left side of the body, our left hip, we're not going to turn them onto their left hip, right? we're going to turn them onto their right hip. If we need to move them. Let's see. Pelvic fractures can result in damage to the internal abdominal organs and can lead to excessive bleeding loss. Muscle spasms, bruising, inability to raise the leg, external foot rotation on the affected side, hematuria, and edema at the site. I will say hip fractures, hip replacements, I'm sorry. Hip replacements, especially in our elderly population, most patients die not too long after a hip replacement. And it's because of infection, okay? Infection gets deep into the bone, okay? And then they become septic, okay? So, again, making sure that we're taking those standard precautions, right? And that we're doing that infection control to prevent that. Let me see. Okay, we don't have that much longer to go. More of this is pictures. So our bone fractures. Okay, we have multiple types of bone fractures, right? Simple, right, where it's just almost like a hairline fracture, right?
Yeah.
A compound where it's a complete break. Okay, it's a complete break, and it can even puncture skin. Okay, this is kind of when you see like bone sticking out of people, right? When they get into an accident, where this is a compound fracture. Then we have a green stick where there's a little bit of impaction, but not completely. And then a comminuted is just literally just broken into pieces, okay? And an impacted is the top of the bone and the bottom of the bone were pressed together. You see this, an impacted fracture, with people who drive with their feet on the dashboard. Like in the passenger seat, they'll have their feet on the dashboard, and then they get into an accident. Because there's that resistance on both ends. So that's typically, that's one of the most common types when you see like an impacted fracture.
Okay.
Here's some more just, transverse, right? Again, just straight across, linear, like up and down. Oblique is at an angle. This is non-displaced. Oblique, this is completely, right, broken off. A spiral fracture, and this isn't like a great picture of a spiral fracture. I'll show you one on x-ray. But a spiral fracture is from twisting, right? So we see spiral fractures a lot in abuse cases, right? Domestic violence, child abuse, okay? When we see kids come in with a spiral fracture, the first thing we think is suspected abuse. Because somebody had to grab, say, the child's arm and twist or pull it, okay? That's how we end up with that fracture. And then here's just some more of what we talked. So here's an x-ray of a comminuted fracture. Okay, so those bits and pieces we see. This is a hip fracture, or a a femur fracture, right? And it's spiral. So see how how this one really shows, like it's like literally looks like a spiral staircase kind of. I didn't have any context on how this fracture happened, right? But there was obviously twisting of that femur bone.
I wonder how that happened.
Compound, right? This almost looks like a complete break, but it's not, right? Here's another view of an impacted fracture, okay? So from one angle, right, again, they just look pushed together, but this is a side view of the humerus.
Oh.
So you can really see, right, how it was like really pushed together and it kind of splints. Because in the first image, right, it just looks like it's like sitting like on top of one another. Okay. So compartment syndrome. Compartment syndrome is very, very painful, okay? Compartment syndrome can happen. Trauma is one of the most common causes. Somebody can have something called chronic compartment syndrome, where the muscle starts getting tighter and tighter and tighter over time, okay? And people will complain that when they run or when they walk, right, they just get this extreme pain in their legs, okay? But when it's full-blown compartment syndrome, right, is when the pressure reaches to dangerous levels, okay? Because of that pressure, we're limiting the flow of oxygen, blood supply, right? And everything that in the blood, right, that nutrients, everything that our body needs, right, for the muscle to get blood supply, right, is now being compromised, okay? And this will even cause compression of nerves. So this person here develops something called a Volkmann's contracture. And this is a permanent contracture as a result from compartment syndrome. So if we don't treat compartment syndrome within roughly 6 hours, okay, we can end up with a Volkmann's contracture, okay? We can cause irreversible damage, okay? And tight casts can do this. That's why it's important. We'll get into cast care in a second. That's why it's important with our casts, we do those 7 Ps, right? We do our neuro checks to prevent compartment syndrome. I'm going to share this video. Why didn't it? When I clicked on it, it did it earlier. And of course, it doesn't want to go. I don't know why it's... Oh, you know what? I wonder if I do slideshow. If I can just... Boom, there we go.
There it is. Okay.
So this is pretty cool. This is a surgeon, and he's... Oh my gosh. Okay, great. Now it doesn't want to work. But he's doing, this is a surgery on somebody with chronic compartment syndrome, but still the process is still the same.
Happens as a result of tight battle after injury. So today I'm going to take you through a surgery called compartment syndrome. There are 2 types of compartment syndrome, acute and chronic. Acute happens after injury or some sort of trauma. And chronic compartment syndrome happens as a result of a tight battle compartment in the leg, and when you run or do any activity, it hurts. There's no trauma involved here. So here's a patient with chronic compartment syndrome. There are 4 compartments in the leg. So we are doing a 4 compartment release. If you come closer, I made an incision on the outside of the leg. This is the anterior compartment. This is the lateral compartment. So I'm here just releasing the fascia. This is the fascial covering of the compartment. As you can see, I'm just releasing it, and you can see the muscle bubbles out. So I'll do the same release on the please. I'll do the same release on the lateral side, which is just here. And you can see the muscle starts to bulge out because the compartment is tight under pressure. So we'll just release it up there and go up a bit. There we go. And as you can see, we have just released the pressure. I'll do the same on the other side. Let's go to the lateral side. So it releases the anterior and lateral from the lateral incision. Here's a medial incision on the inside of the leg. That's a saphenous vein as it comes down the inside of the leg, goes into the foot, takes blood back. This is the posterior compartment. That's the gastroc muscle that goes into the back. Okay, and so I've released the fascia. This is sitting over here of the gastroc, and then here is the deep compartment, and I've just released the deep fascia. This is the fascial covering of the deep compartment in here. Okay, so the deep fascia is covered by the superficial fascia, and that's released there. That's released there. The saphenous nerve that's intact, and the anterior lateral from this side. So hopefully this gentleman won't have any more pain. So now we'll stitch it up. We're ready to go in 10 days. Thank you.
Okay.
So that's a more in-depth view of what muscle actually looks like versus on an actual picture.
So how does that happen? Oh, just to recap, how does that happen when you run again?
Well, compartment syndrome can happen for different reasons, right? So if a person is having trouble with, say, like their muscles or things like that, right?
Mm-hmm.
But for this person, he was noticing it while he was running, right? He was having this pain, and so because it kept happening and happening, and they ran all those tests like we talked about earlier, right?
Yeah.
They determined that he was having compartment syndrome,
Okay.
and so this was more chronic, right? Because remember, he said acute happens like with trauma, right? When we see compartment syndrome, usually it's acute. Okay, it's usually trauma related. But I mean, it can happen. It's just chronically, it's just rare. Okay, but again, once compartment syndrome sets in, right? We have to address it quickly, right? Because remember, within 6 hours, right, we can cause permanent damage, okay? And you can end up with, like, say here, like a Volkmann's contracture. Because compartment syndrome can happen in any part of the body, in any extremity, I should say, okay? So it doesn't necessarily be the leg, just like a DVT. We use the lower leg, the lower extremities, when we talk about DVTs, but you can have a DVT in your arm, right?
Exactly.
It doesn't necessarily mean that part of the body, but these are just the common parts that we have. Usually we see most of this in our lower extremities, and that's because with DVTs and compartment syndrome, and that's because that's our last part of the body that's gonna get that oxygenated blood, right?
Yes.
We're gonna get all that good oxygen is gonna go to our vital organs, right? Our brain, right? All that first, and then our lower extremities is gonna get the last of it. Okay, a fat embolism. Okay, so this is usually associated with trauma. Okay, so remember I said that our bone marrow, right, composed of red and yellow. Okay, and these were in our long bones. Okay.
Yeah.
So, and our yellow bone marrow is mainly composed of fat. Okay, so what happens is there's damage in the long bone. Okay, there's damage to the bone marrow, and fat now enters our circulatory system. So kind of like a blood clot. Okay, but this is fat.
Okay.
And it can travel and go anywhere, just like any blood clot. Okay, so you can have a pulmonary embolism, or it's a fat embolism, right? When we're dealing with fat, but it can go anywhere: the brain, the heart, the lungs. Okay, and so the way to cure that is treatment. Okay, so if there is damage, not just by fractures or breaks, okay, this can also happen with burns. Okay. Especially if we have like a stage 4, like a deep burn that's down into the bone, right? Fat embolisms can happen that way as well, okay? So the main treatment is prevention, okay? And when we have a break of the long bone, right, and when it's a pretty extensive break, we have to be careful on how we move and manipulate the bone to prevent a fat embolism from happening, okay? There's no real big treatment on a fat embolism. Some people say corticosteroids to prevent and treat it, but right now that's still kind of controversial between physicians. So again, just the main thing is to prevent it, okay? So just how we manipulate the bone and things like that. And just like with any clot, right, sometimes we have to go in surgically and remove it. And so it'd be the same thing with a fat embolism as well.
Will it cause the same amount of like damage as like a blood clot, where it kind of like blocks?
Yeah, yes, absolutely. It definitely can, because we're cutting off, we're starving the body of oxygen, right, of that blood supply. So absolutely, it can definitely cause a lot of damage, just like an air embolism, right? It can cause a lot of damage. Okay, a cast. So casts are either made of plaster or fiberglass. Okay, plaster is cheaper and it's easier to work with, but plaster, if you get it wet, it just crumbles. Okay, fiberglass is a little bit more durable, and it dries quicker, and it's more water tolerant. It does not mean that it's water resistant.
Yes.
Okay, it's just it's more water tolerable. Okay, so we still don't want to get our casts wet. Okay, we still teach patient teaching with that, right? Wrap it in like a paper bag or saran wrap or something, right? If they're taking a shower, don't get it wet. The big thing for casts, like when we were talking about compartment syndrome, are 7 Ps, right? And on my left side, I have the 7 Ps, but it's all for basically neurovascular assessment, okay? Skin integrity, right? Because sometimes the top of the cast can like dig and cut into the skin, okay? We want to make sure that the cast isn't too tight because we don't want that compartment syndrome to happen, okay? Patient education, okay, is really big with cast care, right? Because they're going to have it on for, a couple weeks to about, maybe even a couple of months, right? So keep it clean with mild soap and water. And they're going to get itchy. It happens because, guess what? They can't wash their arm or wherever or their leg or wherever the cast is placed on, right? So we have buildup of dead skin cells, right? And so it's going to get dry, it's going to get itchy. But we tell them not to put anything in the cast, okay? For kids, we have to be very mindful because kids will like to take, like itty-bitty Legos and little toy soldiers, right, and stick it in their cast, right? We don't want that, right? We don't want infection. We don't want bacteria, that kind of stuff. And so any type of infection or if the cast becomes too tight, right, that compartment syndrome, or they can't feel like their toes or their fingers, right, wherever the cast is, right, we're having loss of sensation, they need to tell us right away because then we need to cut the cast off, right, and figure out what's going on. The way to remove a cast with both fiberglass or plaster is a electric saw. It's electric saw and it vibrates, okay? We're not gonna cut into the skin, and a lot of people, they get scared with that, right? So we have to say, like, there's really little risk for it to injure you, okay, for it to cut into your skin. So we're going to tell them that, right, to decrease their anxiety because they're probably going to freak out a little bit. And there's going to be some muscle atrophy because remember I talked about, if I just use my right side and I stop using my left side, right, my muscle is going to shrink a little bit in size, okay? And it might be noticeable, it might not, right? But muscle atrophy related to the cast is okay because it's expected. And so eventually the muscle is going to grow back to normal size relatively quickly, okay? So we're not really worried so much about the atrophy and it causing long-term damage or anything like that because we expect that. And then after we remove the cast, right, we're getting rid of all that nastiness, right, that dead skin, right, built up secretions, right, and it's their arm or leg or wherever the cast is probably going to smell, I'm not going to lie. So definitely clean the site, okay? Here's our 7 Ps. I know this, the picture says 5 Ps, but I couldn't find one that had 7. But pulselessness. Okay, so we're looking for, right, do they have a pulse? Is it weak? Is it thready, right? What is it boundy, right? What's the pulse pressure here? Paresthesia, that numbness, tingling, right? Do they feel like there are pins and needles, right? What are they feeling? Paralysis, right? Can they move? Can they move their fingers? Can they wiggle their toes, right? Polar temperature, is the skin hot? Is it cold, right? Because that'll tell us if we have something. With compartment syndrome, the extremity is going to be really hot, right? If they're not getting blood supply at all, right, the extremity is going to be cold, right? Because it's probably going to start turning blue. Pallor, as well, that pallor is what we see visually, right? So it's the color. So pallor is just color of the skin, okay, of the area. Then we have puffiness, right? We're looking for that edema and then pain, right? If they have a cast on, right, we're expecting pain, right, because they broke or fractured something. But if it's increasing pain, right, if it's becoming excruciating, right, then again, that compartment syndrome, right, what's causing that pain, okay? Skin and skeletal tractions. Okay, so we have two types of tractions. Okay, and then within skin we have two types of skin tractions as well. Okay, so traction is just how we use to maintain and straighten alignment. Okay, and the length of our bones after a break or a fracture. Okay. So this bottom picture here, this is a skeletal one. Okay, so this skeletal fractures have to do with pins. Okay, so skin has nothing to do with pins. Okay, but with a skeletal, there's pins inserted. Okay, and then we use heavy weights. Okay, so a pin and a heavy weight is your indication we're dealing with something skeletal. Okay. Because it's going into the bone, right? So we can use a more heavier weight. Now, with skin tractions, we're going to use weights, but they're going to be very light weights, okay? Because it's directly onto the skin, right? And remember, our bones are way tougher than our skin is. So that's why heavy weights versus light weights, okay? With skin, they're going to use a splint or an adhesive, okay, that's applied to the skin with the light weights. And then we have, with the skin, we have a Russell's or a Buck's extension or traction. So with our Russell's here, if you notice, see the it's being supported, right? So there's support here. Whereas a Buck's, there is no additional support, right? So there's no pillow here like there is here, and there is no support on the upper leg, okay?
Yeah.
Make sure for both tractions, okay, we align and stabilize, we relieve any type of, we use it to relieve pressure, okay, we want to make sure they're always in the correct position, and the weight is on the correct weight, so whatever OT or the ortho sets, this is the weight, right, we have to stick with that weight, okay, don't add to the weight and don't decrease from the weight, okay? Ortho sets those parameters, okay? So we have to follow them very strictly, okay? With a skeletal traction, okay, because we have those pins into the bone, okay, we're worried about infection. So make sure that, again, we're using those infection precautions, okay? And again, we use tractions to prevent deformities and relieve muscle pain and spasms, okay? That's why we use skin and skeletal tractions, because we're trying to prevent any type of deformities, okay? Carpal tunnel, okay? This is just compression of that medium nerve, okay? A patient can have numbness, tingling, burning, or pain, or all, okay? Treatment for this is physical therapy, hydrocortisone injections, okay, for moderate symptoms. And then sometimes if we're having severe enough symptoms, then we need to do surgery, okay, to relieve that compression. Patients who are high risk for carpal tunnel are people who sit at desks, right, who have desk jobs because they're typing a lot, hairdressers, nail techs, barbers, right, because they're doing intricate movement with their hands, our massage therapists, okay, even our surgeons, okay, because how they're moving within the body, right, they have to use their hands, right, they have to be precise. So these are our patients who are high risk for carpal tunnel syndrome, okay, so we'll try to tell them to, like, massage, right, rotate, right, takes breaks, right, if they're worried about developing carpal tunnel. I was going to say something else about carpal tunnel, and I lost my train of thought. I did this earlier. I was teaching musculoskeletal, and I literally forgot what I was going to say on this exact same subject. But yeah, I mean, that's carpal tunnel. And then this is just quick assessment of traumatic injury. So what a contusion, a sprain, strain, whiplash, and dislocations, okay? A contusion is just a really, really bad bruise, Okay, it's a really, really bad bruise. Okay, it causes bleeding underneath the skin. Okay, and there's usually not tissue. There's not a skin breakdown with that. A sprain and a strain. Okay, the way to remember a sprain and a strain is a strain, right, has a T in it, and that has to do with tendons, right? Tendons and muscles. So if you see it with a T, we know that's tendons. Okay, a sprain, we know that has to do with ligaments. Okay. Whiplash. Okay, you can have most common cause is from like car accidents, right? You can give yourself whiplash by, headbanging at a rock concert, right? Shaking your head violently, right? You see this with domestic violence victims, right? If somebody grabs them and shakes them, right? Dislocation. Okay, it's just a separation from the bone and the joint. So here, right, the humerus here is disconnected from our shoulder joint. Okay. With sprains and strains, right, we're going to use the mnemonic RISE. So raise, ice, compress, and elevate. Okay. And with a sprain, right, like when you sprain your ankle, right, you can give anti-inflammatories for that too. Same thing with the strain. Eventually, they're going to work themselves out. Okay. Usually, it doesn't require too much medical intervention. Okay. Maybe we'll put like like a wrap on it, right? But typically, it doesn't require too much intervention. Okay. Obviously, a dislocation, a whiplash, they may have to be put in the neck brace depending on how bad the whiplash is, right? Because we want to keep the neck from being hyperextended. And then for dislocations, obviously ortho has to come in and pop that back into place. Let's see. Okay. So bone cancer. Okay, so we talked about bone cancer a little bit earlier, right? We have tumors that are primary, secondary, benign, or malignant. Okay, remember, benign is my non-cancerous tumors. Malignant is my cancerous tumors. And you can have benign tumors that turn malignant. Okay, that's why we try to remove them if we can. If not, we have to really closely monitor them because they can change and become malignant. Okay. Osteogenic tumors are primarily malignant, okay, and they're found in younger people, especially kids. Osteogenic sarcoma, this is a very fast-growing and aggressive cancer, okay? And so even though it affects the long bones, remember I said it can spread to anywhere in the body, okay? Osteochondroma, okay, so chondro is cartilage, okay? So this is cancer of the bone and cartilage tissue, okay? This is usually they're benign, okay, but it can become cancerous as well. Okay. Cancerous bone tumors metastasize and invade other bones and lung tissue. Benign tumors can grow large enough to put pressure on blood vessels and nerves, and again, benign tumors can become cancerous. Treatment goal is to destroy and remove malignant lesions by chemotherapy or surgery. Interventions, post-op, right? So that neurovascular assessment, always monitor vital signs, give analgesics because, again, bone cancer is very, very painful. And if they need a cast, right? So if we had removal of the bone, again, same thing like we talked about for cast care, okay? Dressings, right? They're going to have dressing if they've had surgery, right? So document drainage, odor, right? Any signs of impairment or any signs of infection because it's in the bone. So high risk for infection here. We're going to set them up with PT and OT, okay? And we're going to educate them about home care and then early tumor detection, right? So if they have bone cancer, right, we're going to educate them on how to look for new tumors, or if it's if they say beat the cancer, right, we're going to have them come back and do checkups every few months, and then if those are clear, then a year, right, every single year. But again, we give them that education on how to look for tumors.
Okay.
Phantom pain, okay. I'm sure you know what phantom pain is, right? Usually with loss of limb, okay. The big thing with phantom pain is sometimes it takes the brain a little bit to recognize that limb is not always there. Okay, so sometimes what happens is the nerve is that nerve tract is still intact and hypersensitive. Okay, and so it'll send stimulation to the brain saying, "Hey, like my leg hurts," even though they're missing a leg.
Yeah.
So we have to tell our patient, like, this is a physiologic response. This is not psychological. So they're not going crazy. Okay, they're not going crazy. Because a lot of them will think, like, oh my gosh, what's going on with me, right? I don't have a leg. Why am I feeling pain? So we have to tell them that this is a normal response, okay? Decrease that anxiety and their fears, okay? And this can sometimes last years or months or years. And it's not always, it's not like a daily thing. It's more intermittent, okay? And sometimes if that nerve is really acting up, then we have to do a stump revision where we have to go in and clip the nerve, okay? If it's severe enough. If that pain gets that bad, or we may have to give a nerve block. Okay, but usually our patients will rub the limb, or they'll take an analgesic. Okay, some patients with severe phantom pain will even stab their prosthesis. Okay, to kind of show their brain like, hey, it's not here. Okay, that's more that's like I said, it's pretty extreme, right?
Yeah,
but if it works for them, it works, right? But usually it kind of goes away on its own over time. And then last, we have types of spinal deformities. So lordosis, scoliosis, and kyphosis. Okay, so lordosis in our lower spine, so lumbar, so lord for lumbar. Okay. Kyphosis, how I remember kyphosis is like, say, like the letter K kind of sticks out, right? That's basically what the spine is doing, right? It's sticking out, causing that humpback appearance. Okay, and scoliosis, right, kind of looks like an S, okay, S curve in the spine. They can be very painful, okay? They can, lordosis can affect problems with our hips and our gait, okay, mobility. Sometimes surgery is needed to fix them, okay? Sometimes, a lot of this, if they're not born, say with scoliosis or something like that, right? A lot of this is from poor posture.
Okay.
So, they're going to definitely see physical therapy, chiropractor, they're going to work with ortho, okay? And maybe even a surgeon depending on how bad the curvatures are. And then we're just some quick key terms. A blanching test, if you see that, all that means is cap refill. Okay, this whole blanching test is just cap refill. We went through arthroplasty, so right, joint surgery. Arthrocentesis, remember we talked about when we aspirate fluid from the synovial joint. Callus is bony deposits. So when a bone is healing, right, from being broken or fractured, right, basically this callus, it's like a formation that forms over the bone. And you can see, that's how when we look on x-rays, we can see if somebody's had multiple fractures. Because we're going to see that callus on film. Crepitus again, okay, that's why I told you that bone rubbing, right, sounds like grinding almost. Fibromyalgia, okay, we don't know why fibromyalgia happens, okay, there's no, like, real known cause, okay, but it's chronic and it causes pain in the muscles, bones, and the joints, okay, so we kind of almost treat it like an autoimmune disease, okay, so anti-inflammatories, corticosteroids, and immunosuppressants if needed. Yeah, and then that's kind of everything. Let's see. I'm going to save that because I'm going to kept that. Okay. Let's see. Do you want to do some questions or do you want clarification on anything?
I mean, there's still the farm stuff. I don't know if we have time for that. We got like GI, I think.
We covered a lot of that last week, I thought.
Oh,
Because we covered like antiemetics, remember, acids and all that.
yeah. We just needed diarrhea. The laxatives and the constipation. I think we didn't go over that part.
No, I remember going over laxatives because remember I told you that if we take laxatives, if somebody takes laxatives chronically, it shuts off that part of the brain that says, "Hey, you need to poop."
Yeah. That's true.
Right. So then we rely on laxatives. So it's up to you, hon. We can go through those meds, go through questions. It's up to you.
Yeah, I guess we'll just go over questions for the last 15 minutes or so, and then call that
Okay.
or something.
Sounds good. Okay. So this is going to tell us, right? It's asking us what these symptoms are. They osteoarthritis or rheumatoid? Okay.
Okay.
Client is a 72-year-old male who presents to the rheumatologist's office upon a referral from his primary care physician for worsening arthritis affecting both hands and both knees. He states he's experiencing joint stiffness that lasts for almost an hour upon walking. The client reports feeling unwell for the past week with fatigue and loss of appetite. He's had osteoarthritis, gout, a hiatal hernia repair, and a left knee arthroplasty. So he's had a knee surgery. Client reports pain of 4 out of 10 on his hands and 5 out of 10 to his knees. Some finger joints appeared reddened, warmed, and swollen. Nodules are observed on the metacarpophalangeal joints on the second and third fingers of both hands. The client reports tenderness on palpation. Client is unable to close the hand fully when asked to make a fist. And he's also unable to completely extend his legs due to pain and stiffness. He states increasingly difficulty with cooking and hasn't been able to play golf in months. Vital signs are significant for a low-grade fever.
Okay. Alright. So we just pick.
Yeah. So would you it can be both, it can be one.
Yeah, I mean the stiffness lasting greater than 30 minutes. I'm guessing that's both.
Okay.
Yeah. The joint swelling. I think that was just osteoarthritis. Well, I think both of them too, right?
Okay. Let's do both. And then what about nodules associated with the fingers?
Okay, that one I know is only osteoarthritis, I believe.
Okay.
And then symmetric bilateral joint involvement. Okay, so I think that one's symmetric. I don't know. That might be rheumatoid. Is that rheumatoid?
Okay. It'll show us the answer. So
okay.
you want rheumatoid, osteo, or both?
I guess we'll go rheumatoid on that one.
Okay.
And then decreased range of motion. That should be both.
Okay. And then low grade
fever. I want to say that's just rheumatoid because that one's anti-inflammatory. Oh no.
Okay.
Immuno.
Okay, and let's see. Yes, be rational. Okay. Good.
All right.
Very good. Okay. So the only thing we got wrong here was that osteo for the stiffening lasting 30 minutes, and let's find out why. Okay, for osteo, pain lasts typically less than 30 minutes.
Oh, really? Okay.
Yes. So remember I said that with with both, right? We have that pain in the morning, right?
Mm-hmm.
But osteo, as time goes on, right, the more they start using their fingers or their joints, it tends to get a little bit better.
Okay.
We have that blood circulation.
Okay.
Where RA, it's they kind of can't get away with it. I mean, it can help, right? It'll help, but they're still going to feel that pain and stiffness.
Okay.
Good job. Okay, let's see. The client is a 72-year-old male who presents to the rheumatoid. Oh, this is the same person. Okay.
Okay.
Everything's the same. Orders. Draw blood for inflammatory markers and autoimmune connective tissue disease panel. X-rays of bilateral hands and knees. And the nurses haven't changed. Okay, so what laboratory result is specific for the diagnosis of rheumatoid arthritis?
RF. Rheumatoid factor.
Okay.
Oh, what? What's that? I don't know. I've never seen this one.
Anticyclic citrullinated peptide is a circulating autoantibody that can be found in the blood of clients with RA. This is an autoantibody that is most specific for the diagnosis of RA. Once a client develops a positive anti-CCP, it remains positive when the disease is in remission. So this test is detecting the antibodies that are basically, like, it's looking for the antibodies that are the specific antibodies attacking that joint.
Okay.
So that's what that is. The rheumatoid factor says, despite the name, rheumatoid factor is IgG, and it's not specific to rheumatoid arthritis alone. It can be positive for other autoimmune diseases like lupus and scleroderma. So rheumatoid factor is likely to be positive with an anti-CCP and will remain positive even when the client is in admission. So even though rheumatoid factor is correct, the most correct was the anti-CCP.
So it's more, yeah, that one's, I guess, yeah, because I've never heard of that one. I've only heard of rheumatoid factor and CRP.
Right. So this one's a little bit more in depth.
Yeah. I don't think we ever that's seen it in the book.
Yeah, I haven't seen that one either. I don't think that's why I didn't put on. I was like, really? Okay, so they did the X-rays. Okay, we see the left X-ray of the left and right knees show bone and cartilage erosion with joint spacing narrowing. And then our left and right hand show soft tissue swelling with bony erosions to the metacarpal phalangeal joints. And he was diagnosed with rheumatoid arthritis now. So remember, he has a history of osteoarthritis. Now he has rheumatoid.
Okay.
Counsel on life adjustments and pain management strategies. So when creating a care plan for a client with rheumatoid arthritis, the nurse should prioritize interventions and prevent
joint destruction.
Okay.
Oh,
and reduce
systemic inflammation.
Okay. And let's see.
Oh,
correct. Good job.
Yeah, I almost second guessed myself on that one.
Don't say you got it. You got it. Okay, so let's see if anything changed. No. Oh, we have lab results back. So our CRP is, we got ESR positive, right? But again, he was, his diagnosis was right, RA. So which statements regarding rheumatoid arthritis by the nurse are correct? Select all of that apply. Paraffin wax can soothe joint pain and stiffness. Physical therapy can help preserve range of motion. Alternative therapies usually aren't effective. Eat plenty of vegetables, whole grains, and healthy fats. Keep your joints active during flares.
Okay, I know the range of motion for sure.
Okay.
I don't know what paraffin wax does.
Paraffin wax is how do I describe it? It's like a big thing now when you get like your feet done and stuff.
Okay.
It's basically like a hot wax. For like when you get your feet done, they usually use it to like help remove calluses. But it's like a hot wax. Think of it like a heating pad kind of thing, but wax.
Okay. Yeah, then that'll probably work with the joint pain and stiffness.
Okay.
Okay, and then I guess the last one will probably be the eat vegetables, whole grains, and healthy fats.
Okay.
I don't know if you're supposed to keep your joints active though, but yeah, let's just stick with those.
Okay. And you got them all. Good job. 3 out of 3. Okay, so heat and cold application says this parfum wax may be beneficial for pain management. Cold aids in reducing inflammation. So that again, and that's why we said, we want to encourage them to use both. Some people prefer cold, some people prefer hot, right?
Yeah.
Mediterranean diet is, remember those anti-inflammatory foods I was talking about, right?
Yeah.
An anti-inflammatory diet. That's a Mediterranean diet is mostly anti-inflammatory. Okay. So I have the oils, fats, vegetables, and then so during that last one, remember that you were like, you don't know if they should be active.
Yeah.
Joints should be rested during active flare-ups. Okay. So when experiencing pain, stiffness, and swelling, continuing to use the joints will worsen symptoms because we're just adding on to the stress. Okay, so the doctor ordered prednisone 40 milligrams by mouth every day for 1 week and then taper as instructed. Methotrexate every week, right by mouth, folic acid, diclofenac by mouth every 8 hours, a CBC. LFTs now repeat in 1 month and then every 3 months, and then they're going to follow up with rheumatoid allergies. So drug class. So what drug class is prednisone?
Should be a corticosteroid.
Okay. And client 16?
Suppresses the immune. Wait, yeah, it does. Yes, suppresses the immune system.
Trying to see if they. Okay, yeah, because it reduces effects of medication, promotes muscle relaxation. So suppresses immune system. Okay, methotrexate.
That should be a DMARD.
Okay. And then what does this do?
I believe that should also do immune suppression.
Okay.
I don't know what diclofenac is, to be honest. But judging by what we're missing, I'm guessing that's an NSAID.
Okay. And then, so then what do instead?
Yeah, pain.
Pain. Oh, look at it. You got them all. So methotrexate slows the disease progression.
Okay.
Okay. But great job.
All right.
And I loved how you rationalized this medication that you didn't know. Right? Because you used that rational thinking. Well, we have this and we have this. What we're missing is an NSAID, right? Good. I will say, you are the one student when I tutor I don't worry about. I don't. So my students, I'm like, okay.
Yeah, I just try to make sure that I have enough what you call it. Try to have enough repetition.
The only problem I see with you sometimes is you go a little too in depth.
Yeah.
Right, and I'm like, that's great, but
there's a more obvious answer that.
Right. I mean, not that, but I mean, it's great. I love that you're knowledge based, that it's expensive, but I don't want you to overstudy. I don't want you to
Yeah.
I want you to more focus on the key things, but you're great on that. So I don't, like I said, I don't really worry. Okay. Any nurses' notes, labs, imaging studies, orders. Nope. Okay. So, click to highlight the findings that suggest the client has not yet achieved a state of low disease activity. On exam, the client has 2 swollen and tender joints on the left hand and 1 to the right hand. He voices stiffness lasting almost an hour in the morning. He experiences weekly episodes of nausea and reports occasional tender cracks and small sores in the mouth. The client states he has noticed an increase in energy. He was able to play 9 holes of golf last week. In reviewing recent lab work, the nurse notes an ESR level of 28, CRP of 20, and an AST of 100. So it's asking what suggests that the client has not achieved a state of low disease activity.
Okay, so I'm guessing the first one because it's still swollen and tender.
Okay.
The stiffness is lasting longer.
Okay. I'm just highlighting because I want to see what it'll let me highlight. Okay, it'll kind of basically let me highlight everything.
Okay. So the nausea and the episodes of nausea and the tender cracks and small sores.
Okay.
Yeah. Okay. And honestly, I don't know the lab ranges for these. So
I don't either. So it's okay.
Yeah. So I guess I'll just stick with that since I don't know the lab.
Okay, so the only thing you missed was our ESR and our CRP, and the reports of tender cracks and small sores were not related. Let's see. So episodic nausea related, tender cracks and small sores and elevated AST. The methotrexate side effects.
Oh, okay.
Mm-hmm. While these require further exploration, they don't provide information on the client's activity or medication effectiveness. So it's just a side effect is all.
Okay.
Yeah. But other than that, you did, again, really good job. Let's see. The nurse is caring for a client with arthritis who is taking naproxen, so a lead. Upon assessment, the client reports weakness, fatigue, and shortness of breath. Which lab value is most important for the nurse to review? PT time, hemoglobin, potassium, or erythrocyte sedimentation rate?
Yeah, we didn't really do too much on labs, to be honest. Sedimentation rate. Okay, so that's blood. Thrombin time. I guess I want to say hemoglobin.
Okay. Correct.
All right.
You're just guessing.
Yeah, because I don't know the other ones. Well, except for potassium, obviously, but that's heart related.
Right.
Yeah.
So because they have weakness and fatigue and shortness of breath, these are constant with anemia. So if they're taking naproxen, right, because this is an NSAID, this can increase our risk for bleeding. Remember that GI bleeding?
Yeah, NSAIDs, yeah.
Right, so that's why we're going to look at that hemoglobin, Allopurinol is prescribed for a patient with a 55-year-old client with a history of gout. When performing a medication reconciliation, the nurse notes that the client is also taking aluminum hydroxate for gastric reflux. Which medication instruction should the nurse discuss with the healthcare provider? The client should stop taking the aluminum hydroxate immediately to prevent adverse effects. The client should take allopurinol at the same time as aluminum hydroxide to increase its effectiveness. The client should separate the aluminum hydroxide and allopurinol by at least 2 hours. The dose of allopurinol should be increased to compensate for the decreased absorption by the aluminum hydroxide.
Separated by 2 hours.
Good job. Remember we covered that last week.
Yeah.
Remember we give
Antacids
antacids,
and all that,
right? We give our antacids first, right? Because again, if we don't give them, they're just going to vomit anyway.
Yep.
So we give those antacids, and we have to separate it because our antacids affect
Absorption.
the absorption. A client with well, here we go.
Yeah.
A client with rheumatoid arthritis has developed oral stomatitis. The client's medication list, what medication to the nurse ask the healthcare provider to hold. Naproxen, Medrol, methotrexate, or Enbrel.
I want to say naproxen.
Okay.
Oh.
And it was remember we just did, remember the methotrexate causes
Yeah.
oral sores?
Okay. Oh,
Remember-
is that the one?
Yeah, it was this one. See, remember the methotrexate? Remember when we did that highlighting portion? And you had
that's
selected
that.
sores?
Yeah.
Mm-hmm.
Yeah.
It just only 33% of students got this correctly, so this was
Yeah. 'Cause,
a hard one.
we don't even have like a little section for methotrexate in our book. I don't even think.
Oh, really?
I had to actually research that myself.
Oh, see, that's why I'm not a huge fan of ATI
Yeah.
because I feel there's so much gaps in it, right?
Yeah. The actual textbook didn't have it, but the ATI book did. But yeah, it's just, I don't know. I really wish they had more info on it.
Right.
Yeah.
Do you want to do the full 20 or do you want to stop at a certain point?
Yeah, we could just make this the last one, and then
Okay.
yeah, I guess I don't want to overload myself.
Okay, the practical nurse is caring for a client with short leg cast following a left tibia fracture. During morning cares, the client reports tingling and severe pain in the left lower leg and that prevented them from sleeping despite receiving a PRN instead every 4 hours. The practical nurse observes that the left toes are pale and cool to touch. Which action should the practical nurse perform first? Provide prescribed as-needed dose of ibuprofen 400 milligrams by mouth. Check the client's pulse ox level. Request prescription for an alternative analgesic. Notify the registered nurse and the healthcare provider.
All sucks.
It was
What?
D.
Oh.
Because
Too late.
that's right. So this is compartment. So the first thing we're going to do is we're calling the RN and we're notifying the provider.
Oh.
Yes, we're going to do a pulse ox. Okay, we're going to check.
Mhm.
But the first thing we need to do is we need to notify the registered nurse and the healthcare provider
Yeah.
because we don't know how long this compartment syndrome has been going on.
Okay.
And remember, we said 6 hours is that window right before we start that permanent damage, right? So we have to get this cast off.
Okay.
But other than that, good job.
Yeah. Sorry. Yeah, because usually when I have these questions, they always say something about how you're supposed to take the vitals first and assess first before you even notify anybody.
And that can be tricky, right? Because we're always thinking our assessment first. But the big thing is because our assessment, right? We observed that the left toes are pale and cool to touch.
Okay.
So that already tells us we're compromised, right?
All right.
That already says, okay, we have something really going on, right? We need to remove this cast because we're going to lose that extremity.
Okay, so this compartment syndrome is either going to be either too cold or too hot, or just one temperature.
Compartment syndrome, so with the swelling, it will be warm, okay?
Uh-huh.
But in the distal extremities, it's going to be cool because it's stopping that supply. It's stopping that blood supply.
Okay, so the closer it is to the core, the more warm it'll be, and the further
Yes.
away. Oh,
So I'll put it. So if we took off the cast,
yeah.
I guarantee you that tibia is going to be warm. But notice it says the left toes are pale and cool
Okay.
because that's the distal stuff, right?
Oh, so that's where it's stopping. Like at
Right,
the tibia.
exactly. So that the part where compartment syndrome is happening is going to be warm, but just like with the DVT, right? The DVT site is going to be warm, but the extremities, or like the say the fingers or the toes, wherever that DVT is, right, or compartment syndrome is, those are going to be cool and pale because we're cutting off oxygen supply.
Okay. All right. That sounds good.
Yeah. So, but good job today.
All right. Thank you so much.
You're welcome. I hope it helped.
Yeah, appreciate you doing this. Yeah, it definitely helps.
No problem. No problem. And thank you for sending me the PowerPoints and stuff because it does. It really helps when I know
what we're
you
covering.
guys.
Yeah.
Right. Because sometimes, especially your guys' farm stuff, man. Because especially the PowerPoints I get from you guys, I'm like, I find myself stumbling over stuff because it's the first time I'm seeing the PowerPoint.
Yeah, of course.
So I'm trying to read the PowerPoint, but then I'm also trying to like think of ways to make it connect. So when it's new and it's the first time you're seeing it, you're like, okay, wait, you have to backtrack a little bit. So,
of course.
But yeah, so if you have any questions, let me know, and let me know how this exam goes.
Yeah, I will. Thank you so much.
You're welcome. You have a good night, huh?
All right. See you.
All right. Bye.
What's this? Oh. Musculoskeletal.